Welcome to this explainer, where we're going to be unraveling the incredibly complex, dynamic process of acute pancreatitis. We're taking a pretty fascinating journey today. We aren't just looking at the textbook theory. We're taking that deep, cellular pathophysiology and translating it directly into concrete, evidence-based management. So whether you're here for a clinical refresher, or you just really love seeing how macro-level patient care stems directly from micro-level biology, you are absolutely in the right place. Let's get started. Okay, quick look at our roadmap. We'll start by redefining the disease, move right through the triggers and cellular pathways, cover the clinical presentation, and then focus heavily on evidence-based management and the surgical step-up approach. Section 1, redefining acute pancreatitis, moving well beyond the old theory of autodigestion. For over a century, basically since Hans Cherry proposed it, we've taught that acute pancreatitis was just premature enzyme activation. The idea was simple. The pancreas is basically eating itself. But modern research shows us it's really not just some simple plumbing problem. It is a highly complex, cascading molecular failure of the body's cellular defense mechanisms. It's a profound molecular and immune system collapse. Section 2, triggers and cellular pathways. Let's explore exactly what initiates this devastating cascade. We all know the classic etiologies, right? Gallstones, alcohol, and high triglycerides. But let's look at the actual mechanisms here. Gallstones cause a mechanical obstruction and bile reflux. Alcohol alters the fluid viscosity and creates highly toxic metabolites. And hypertriglyceridemia, that actually triggers NLRP3 inflammasomes, causing a fiery, highly inflammatory programmed cell death called pyroptosis. So while these triggers initiate the cascade through vastly different biochemical mechanisms, they all violently converge on one specific target, acinar cell injury. And this brilliantly illustrates why alcohol is so damaging at a microscopic level. It's not just about the volume a person consumes. Ethanol is metabolized into reactive oxygen species and FAEEs, or fatty acid ethyl esters. These toxic FAEEs literally accumulate inside the cells, destabilize the membranes, and release massive calcium stores that completely cripple the cell's internal organelles, like the mitochondria. And sometimes this even synergizes with genetic mutations, like Claudin-2, to severely accelerate the inflammatory process. In fact, even our genetics can set the stage without any external triggers at all. Advances in genomics show us that mutations like PRSS1 eliminate autolysis sites, or they increase the autoactivation of trypsinogenin. This really proves that pancreatitis is fundamentally a molecular failure, a total disruption of that delicate balance that's supposed to prevent enzymatic autoactivation. So let's look at the actual cascade and see how this builds from local acinar cell injury to a completely irreversible state. Obviously, it starts with that premature trypsinogen activation. But step 2 is where it gets fascinating: ductal cell failure. When bile acids reflux, they activate receptors that cause a massive calcium influx through apical ORI1 channels. It's essentially throwing open the floodgates to calcium, which destroys ductal function. This highly toxic environment then leads to step 3, the breakdown of endothelial integrity and acute disruption of the microcirculation. And that right there is the critical turning point. So the crucial takeaway here is that early microcirculation alterations pave the way for a massive systemic catastrophe. The timeline is wild. In just hours, it's a localized swelling. But within days, M1 macrophages and destructive nets from neutrophils trigger a massive systemic inflammatory response syndrome, or SIRS. Now, the body tries to fight this in the following weeks with CARS, a compensatory anti-inflammatory response syndrome. But this overcorrection swings the patient into a highly dangerous state of lethal immunosuppression. This allows gut bacteria to translocate, ultimately causing deadly sepsis. Section 3, clinical presentation and diagnosis. Knowing all this cellular chaos, what are the signs and symptoms at the bedside? A meticulous history is absolutely essential. The onset is often much more sudden in gallstone pancreatitis compared to alcohol-induced cases. Patients will classically describe pain radiating to the lower thoracic back, often in this very distinct band-like pattern. Always dig into their medication history. Drugs like azathioprine or mercaptopurine are known culprits here. Symptoms like nausea and malaise are super common, and this is a big one. If you see agitation and confusion, pay close attention. That is a massive red flag indicating severe systemic organ dysfunction. Now, a quick warning based on the clinical guidelines. We all learn in school about those dramatic cutaneous signs, right? Cullen's or Gray-Turner sign, that ecchymotic bruising around the umbilicus or the flanks. Please do not rely solely on finding this bruising to make your diagnosis. These signs of complicated hemorrhagic pancreatitis are incredibly rare. They occur in only about 1% of cases, and they often appear way late in the game, well past the 24 to 48-hour mark. And actually, speaking of that time frame, the number 48 is incredibly important. 48 hours is our critical threshold for classifying the severity of the disease based on the duration of organ failure. Using the revised Atlanta classification really helps us categorize patients efficiently. Mild acute pancreatitis is the most common. No organ failure usually resolves in a week. But focus your attention on the moderately severe classification. It's defined by the presence of transient organ failure. That means the organ dysfunction is present, but it clears up within that critical 48-hour window. If it persists beyond 48 hours, now we're dealing with severe acute pancreatitis, and that carries a significantly higher mortality risk. Okay, bridging the gap between that devastating molecular theory and actual patient care, let's jump into our primary evidence-based management protocols derived directly from clinical guidelines. Look, if you take away one single clinical rule from this entire explainer, let it be this exact guideline. Early administration of crystalloid IV fluids is of critical importance in all patients with acute pancreatitis, however mild. We literally cannot overstate this. And now, because we just broke down the underlying biology, you know exactly why this matters so much. We aren't just hydrating the patient, we're actively fighting the pathophysiology. Because the disease process attacks endothelial integrity and causes a massive fluid shift, aggressive early fluid replacement is absolutely critical to maintaining that pancreatic and systemic microcirculation. It is quite literally the only way to halt the progression to multi-organ failure and ultimately save lives. Alongside that fluid management, vigilance is your best friend. Assess for organ dysfunction immediately on presentation, particularly cardiovascular, respiratory, or renal. And remember that systemic timeline we discussed earlier? Identifying SIRS, systemic inflammatory response syndrome, immediately on admission is our best, most sensitive tool for predicting the risk of a fatal trajectory. If SIRS is present, you have got to be incredibly proactive. Section 5, the step-up approach. What happens when our standard medical management just isn't enough? Well, when dealing with infected necrosis, surgical management has evolved quite a bit. We no longer just rush into an open surgery. Instead, we rely heavily on the evidence-based step-up approach. You always start with the least invasive method first, catheter drainage, which can be done percutaneously or endoscopically. You only step up to a more invasive surgical necrosectomy if that initial drainage proves unsuccessful. This stage strategy significantly minimizes trauma to an already critically ill patient. Looking to the future, this detailed molecular map we've explored today really opens the door for some incredible advancements. We are actively researching targeted therapies like inhibiting those toxic ORI1 calcium channels, or using long-acting trypsin inhibitors, or even modulating the gut microbiome. We might one day be able to stop this disease right at the acinar cell before the systemic cascade even begins. To wrap up, acute pancreatitis is absolutely not just local autodigestion. It is a profound, incredibly complex transition from microscopic cellular failure to macroscopic systemic catastrophe. But by understanding the mechanism from micro to macro, you are now fully equipped to manage this emergency efficiently, prioritizing that aggressive early fluid management and vigilant monitoring. Thank you so much for joining this explainer, proudly brought to you by Clinical Meetings Group 4445. As we look to the future, if we can eventually target and shut down these specific inflammatory pathways, will acute pancreatitis transform from a systemic, life-threatening crisis into a simple, manageable outpatient condition?